Okay, here we are today, and we're going to have a discussion about palliative care and dementia. And our guest today is Dr. Tara Kattine. Wait, there she is. And she is an MD, and she recently finished a fellowship in palliative and hospice care. And she's going to tell us her background. And then Rita, wave Rita, is
Hello.
an FCD spouse. And Janelle, wave Janelle, is also an FCD spouse. Rita currently has her husband living at home, as do I. And Janelle had her husband in a memory facility, and he passed away in 2017. And she wants to help people be educated about palliative care because she wasn't offered that. And we want to bring out how important it is to the dementia community to try to become involved with palliative care. So Dr. Kattine, if you will please tell us about your history and how you are associated with palliative care, we would appreciate it.
Well, I've been working in palliative care by way of, been doing it for such a long time. I started off in hospice care in January of 1999. And that was around the time that palliative care and hospice were thought to be the same thing. But shortly after that, palliative care took on a life of its own. So I've been working in palliative medicine and hospice separately since the 1990s. And over the past year, I've been doing a palliative medicine fellowship in Columbia, South Carolina, so that I can hone my skills and then become board certified.
Well, we appreciate you being here and able to answer our questions. Let's start out with the big one that everyone gets confused. Tell us how palliative care is different than hospice care.
Well, that's a really good question. I tell you, people always get those confused because back in the day, they were thought to be the same thing, and people use those phrases interchangeably. What happened, people in hospice care were getting referred very late. The bereavement surveys would come back to the offices saying, our biggest complaint is that we got referred so late in the illness that we didn't get the benefit of the service. And then from the medical community, people were saying, why do you have to be terminally ill to be able to have your symptoms managed, have your quality of life looked at, have support for the family? Why don't we make this a service available to anybody, not just those who are coming to the end of their lives, but service that can be offered at any time during the course of an illness, starting with the time of diagnosis. So they use an interdisciplinary team at its core. Is a nurse, a social worker, chaplain, doctor, but anybody important to the care of the patient, a pharmacist, a therapist, the family and the patient can also be considered part of that team. And the goal is to focus on quality of life, relief of distressing symptoms, and support as necessary for all the people involved, the patient and the family. And that can start from the time of diagnosis. The palliative care service looks at a patient as a whole person, not just a disease entity that needs to be worked up and treated. And as I said, can be provided at any time during the after the diagnosis or at the time of diagnosis in conjunction with the life-prolonging care, unlike adult hospice. So you can have all your life-prolonging care provided simultaneously to the palliative care.
And I think it's an important distinction between palliative and hospice. Hospice, obviously, you go off of any curative care, although in dementia, we know there isn't a curative path. However, that's why I think it's more important for dementia people to be on palliative than any other serious disease because there isn't a treatment and there's a lot to navigate.
Yes.
I'm gonna ask you a question here. Can you also address about physicians, because obviously we all are with our primary physicians, and how is palliative care different from the traditional concept of medical treatment that many physicians might be more familiar with?
Let me see if I can break that down a little bit. Most of the time, we go to medical school we don't think about how we can help make people be comfortable as they're facing their illnesses. We look at trying to make sure people are getting better, figuring out what's wrong, and that tends to be the focus. And you worry that if you don't do those things, you're doing the patient a disservice. So in palliative care, the service often will try to translate what the doctor is saying to the patient, because sometimes they just speak in medical jargon, and you want to make sure the patients and their families understand what they're talking about. But you also go back to the primary physician and say, this is really what's going on and this is where it's headed. Are you sure these things are important to the care of the patient, to help them achieve their goals for how they want to live their lives and for the care they really want to have? Is that answering your question?
Yes, it does. I think a lot of physicians, when we go to our primary physician and request palliative care, what are the important things for us to mention to them?
You mention to them, number one, that you want that service, that you don't have to stop going to your primary physician if you have palliative care and you're coming to you or you're going to their clinic. And that what's important to you is to make sure that your quality of life is addressed and not just the disease management. Is there something in particular that you were thinking of?
No, that answers my question, because a lot of times when we go to a primary physician that may not be as familiar with palliative or is in a location where palliative is not readily available. I'm in Atlanta. I have the choice of about 15 different palliative centers. So I'm fortunate to be in a very large city. But Rita, do you want to address from your perspective in sort of rural Wisconsin, how that might affect you?
I'm in a very rural area, and I was on a website where you could look up to see where your closest palliative care office was. Well, I don't know if this was the only place registered with that site or what, but it was like hours away from me. So that's one question I had. How do you go about get started with palliative care? Do you go through your primary physician? Do you look for agencies that are near you and contact them yourself? Because I'm not even sure where palliative care is close to me.
Your palliative care is growing by leaps and bounds, but it's still hard to find. And I always start with Google, honestly, but there's a website called Get Palliative Care. It's out of the Centers to Advance Palliative Care. And you type in your zip code and they try to match you up with what's available in your area. And I tried doing that, and there are more than what they have registered there. So people have to be, or services have to be registered to be able to be offered through that site. So Google is one way. And you can always call a hospice and see if they have that as a complimentary service. Usually they'll brag about that in their literature if they have that. Sometimes it's offered through a home health service or a bridge program, as they call it.
Are you familiar with a GRACE? Is that something that's just in this area, or is that something that?
I am not familiar with that, no ma'am.
Okay, we just had a GRACE agency open up about 20 miles away from me, because I do live out in the country. And I know they have hospice, and I was going to check to see if they have palliative, because I'm going to guess that they do, but I would have to check to know for sure.
You could also check for physicians who are certified in palliative medicine, and you can contact them directly.
Okay.
Janelle, I know that you were not afforded a palliative care. I'm sure that part of it was that it was probably at the time when palliative and hospice were sort of interchangeably used. But what would have made you look at palliative care? Was it lack of education that no one knew about it, or why did you feel you weren't able to get palliative care?
Well, I didn't know where to go. I wasn't smart enough back then to think about, well, Google it. And I ran into my primary care physician, was not familiar with someone having this kind of the FTD in their 50s. And to him, palliative care was the step before hospice. But it was like, okay, you know, because he originally had said, well, you don't qualify for hospice, when I kept pushing on palliative, you know, because I was like, and so I think he has had the learning curve, and he was quite new here in town. So I don't know if that was that combination or, you know, whatever, but I just basically said, you know, it's quality of life, not quantity of life with this disease. And I kept saying that over and over and over when he wanted to do the diagnostics and the colonoscopies and all that other normal yearly things. And I just finally said, I'm the power of attorney, and I say quality versus quantity. And I know he had a hard time because he felt that it was as though he had given up. And he did not admit that to me until after Keith passed away.
So how do we get around something like that, Dr. Kattine? If we go to our primary physician, how do we approach that primary physician?
I think you have to really be a strong advocate for yourself and for the people that you love and insist on it. You can also, I mean, it should be the other way around. The doctor should be looking after you and your needs, providing you the support. But I'll say doctors are only human, and they get attached to their patients, and they want to do what they were taught to do, and they don't want to feel like they're abandoning them. Yep. So I think that if you go to your doctor and say, this is really important to us, and I know what he would want. I know what my loved one would want in this setting, and having that colonoscopy is not something he would want. What we really want is to pack as much life into every day and not have back and forth to the hospital, back and forth to procedures, back and forth to clinic visits that aren't really going to help him live the life that he would want to live. And can you help me do that? And I hope that you'll find me a palliative care physician to help me do this, or a palliative care service or clinic, so that we can figure out how to move forward in the best way for all of us.
So advocacy for the person that we are caring for is very important in this issue, because palliative is was always associated with hospice. That sometimes is the pushback that you're not far enough along. How do you answer that question to a primary physician when they, like Janelle came across? You're not anywhere near that yet. How do we say, yes, we are?
I would say I'm not talking about hospice. I'm not ready for hospice. He's not ready for hospice. But we are ready to make sure that our quality of life is as good as it can be. We are ready to help us navigate the complex medical system so that we can figure out what is good for him to have and what isn't good for him to have. We can go to him and say, this is what we want, and please help us get it.
That was one of the questions I kind of had was, I'm going to just use me as an example. In our case, my husband can stay home by himself still. We have a few things set in place, like Meals on Wheels. I have 4 security cameras at home, so I can check in on him at any time and make sure things that are fine when I'm at work. He's not on any pain meds, so he has no pain management. And that was kind of my question. What would palliative care do for us at this point when I don't really know what it is that he needs?
Well, they try to help figure out what you need. They look at you and how you're managing. They look at him and see how can he be best served, what kind of resources can they get for him and for you, how they can bring those resources to you and give you the service that you need. And if, say, you have transportation trouble, say you need respite, they will help you find those things and help make sure that you have your needs met as well as him having his needs met.
Would they even help organize, I think we're about to the point maybe this school year that maybe I start having somebody come in once or twice a week for an hour or two, just so he gets used to somebody being in and out of the house. Is that something they would help set up?
They could help you find that resource, absolutely.
Okay.
They probably wouldn't provide it themselves, but they could help you find the resources available to you. And there are many. And I'm sure you've been through to the Alzheimer's. I know FTD, and there are a million types of, well, maybe not a million, but there are lots of types of dementia. But they have such good resources for you and can help you get those things too.
That I've been going through mostly, it's called ADRC here. It's our Aging and Disability Resource Center. And they've been providing a lot of that assistance right now at this point.
And there's a national aging center, national aging, I can't remember the name of the site, but there's a national aging website that can be helpful too.
A lot of the issues that we come across are the fact that a good deal of our population is much younger than an area agency on aging that people would commonly go to. You know, people will say, oh, we'll call your area agency on aging. Well, that doesn't work for the population that FTD affects. And I think that that's probably also one of the reasons why it's so important to try to get palliative involved early on, even if you do have an ADRC that might be helping you find resources. Wouldn't you say, Dr. Kattine, that palliative will take care of that whole person, as you said? So ADRC might refer you to resources, but they're not really going to say, what do you need, Rita? What's your biggest challenge? Do you feel that that probably is the difference there?
Absolutely. That's a very good point. Yes, especially in the population of those kinds of dementia patients. It's so unusual for people to think that a younger person could have dementia, that's really an important point, that the area center on aging wouldn't be as good of a resource. Yeah.
They were puzzled because my husband was in his 50s. They were puzzled and they were like, well, we don't really have anything for, we're for the older. Even my Alzheimer's association here in town was well, we're not geared to help younger. We don't know where to tell you to go for resources because ours are for elderly people.
That tells me that we need to do some education in those communities so that they can figure out that there's a resource for the younger people when they come looking for help from them.
That's why I'm trying to get involved so I can get them up to speed.
I've sort of created a troop of advocates, Dr. Kattine. I became, I called myself yesterday, I think it was, I said, I'm an advocate bordering on activist.
I like that.
Well, I am. I'm a pretty strong advocate. Some people here in the state of Georgia under GUARD, which Dr. Kattine has become involved with now. Yay! Because I want someone in her position of palliative to carry home to the people that are making these decisions on a state level that this is available to those under age 60 right now. And we don't have to wait for House Resolution 1903 to become a bill and be passed and signed before we can ask for services. So I think that's a very important thing to bring out about younger people. And that's what we really want to impart on people today is, and in watching this, that you are entitled to, and almost all insurance companies and definitely Medicare covers palliative care. There could be some copays with your independent insurance if you have that rather than Medicare, but it almost universally is covered. And there may be some copays. It's not like hospice where they're going to bring you incontinence supplies and bring you medications for free. that is not palliative care. Could you kind of address that, Dr. Kattine, about how payments go and who's responsible for what?
Well, palliative care is covered by insurances in the similar way that traditional medicine is covered. Hospice is covered under Medicare Part A. There's a hospice benefit for Medicare, and that covers everything related to the terminal diagnosis. They don't provide 24-hour care, but they will send a nurse, a social worker, a chaplain to the home to make sure that you have all your needs and resources. They cover all the medicines and medical equipment that are needed, that are related to the terminal diagnosis. They cover bereavement. That's one of the other things that's different from hospice than non-hospice palliative care, is that there's that bereavement coordinator who calls or sends mailings and checks on the loved ones for 12 months after the terminal illness has taken its course and the patient has died. So there's the Medicare Part A hospice benefit that covers all of that. It doesn't cover things not related to the hospice diagnosis. That goes back to Medicare. You can still keep hospice is kind of a type of palliative care. It's not completely different. It's under the umbrella of palliative care, and palliative care is not covered under that hospice benefit. It's covered under your other part of your insurance or under Medicare Part B.
Yeah, that's why there could be co-pays and so forth. Is that correct?
Yes, ma'am.
Yeah. But it also, palliative care, because they talk about the caregiver as well, could you talk a little bit about how palliative supports the caregiver?
This is another reason why that interdisciplinary team is so important too. Not only should the physician be checking on the caregiver and making sure that the caregiver is managing okay, can get his or her needs met, in addition, while they're caring for the sick person, that interdisciplinary team can help provide resources for that person or help locate resources if they're unable to do it themselves. And there's so much suffering that goes on. It's not just the patient who's suffering. In fact, probably the patient may be even suffering less than the caregiver. And that suffering has to be managed. And you can't, what is the expression when you're on the airplane, put the oxygen mask on you first? So you have to take care of the caregiver so that they can help the patient.
Janelle, do you have anything that you want to add to that?
Oh, well, that I could have definitely used that. So yeah, I haven't gone to talk to the hospice again. I talked to them briefly a couple of months ago, and they were in the process of moving from one building to another building, and it was a mess. So I'm giving them time to settle in, and I'm going to go back and just see what do they offer.
One of the things the hospice can do is, they could evaluate and make sure that a patient does not meet the hospice criteria. If they meet the hospice criteria for admission to the hospice program, that could be a terrific resource as well. More than likely, people are sick a lot longer and not terminally ill and not getting resources. I'm not saying this very well, but hospice is are supposed to be a benefit for the last 6 months of life. So there are all those years before that, and it's hard to figure out when the right time is for hospice to come in. But hospice is a terrific resource, and if it's time for hospice, it's not a bad idea to get them to come in and give their input and see if they think that you're ready for hospice.
And does palliative, if you're under palliative care, does that not help you to know when you're ready for hospice?
Absolutely. If palliative care services are being offered in an intensive manner, they're really involved, they can help you determine when it's time for hospice. And there could be a seamless transition from palliative medicine into hospice care.
So it is a transition. Once you qualify for hospice, then palliative care backs out and hospice takes over. Is that correct?
In a sense, palliative medicine, it depends on how it's being delivered. There are so many different ways of getting it. There are some communities where they come to your home. There are some communities where it's in the clinic. There are some communities where it's only in the hospital. There are some communities where you have all of it. And so it depends on how it's being delivered. And if the home service that's providing hospice also has that bridge program, you may have the same people who go from home health or palliative care into the hospice services with you.
If we're in an area that, as Rita was saying, when she looked at the list, there was like one and it was very far away from her, how do we advocate to have more palliative care in our local area?
I don't have a good answer for that, but my feeling is that you start with the area healthcare agencies, including hospitals, asking for the service, and then moving from there to talk about it in social media, politically, and trying to advocate for your community, which is hard to do when you have somebody sick in your home that you need to help take care of. So one of the things that I've started locally for us is a palliative care interest group, so that we can see what we can do to help our community and educate people and help grow our services locally. And
well, I truly believe that maybe all palliative cares are not registered with that one website, because I'm an hour from Madison. Madison's a huge community, teaching hospitals. I know there's palliative care in Madison, but nothing popped up for Madison for me.
Right. And I agree. When I looked at my own community, I didn't see everything that is here, and some of the things that I saw were inaccurate.
Yeah. So it does take our searching for it as well, because maybe if we just go to one site and we say, oh, well, there's no palliative here, and we'll just keep doing what we're doing, that doesn't mean it isn't there. I have read recently that over 80% of hospitals now have a palliative team. Would you, if you were not in a hospital situation, would it be appropriate to contact that hospital palliative team and ask where you could receive home palliative or clinic palliative in the area?
Absolutely. Absolutely. I think that in hospitals that have over 300 beds, that more than 90%, like more like 99%, have a palliative care service if you have a big hospital. The smaller hospitals are less likely to have it. If it's a less than 50 bed hospital, they're less likely to have it. But I think if you called the case management at a hospital, the case management service has to have resources for their patients when they're discharged. So that's another way to look for someplace closer to you. I'd call the closest hospital, ask for the case management department, and see if they can help you with that, or social work department.
That's very good advice, because sometimes people just don't know where to go. And the palliative services encompass the whole person. So all palliative services include a spiritual type of counseling. It includes the family, as you said, bereavement. Can we talk a little bit about, does it also handle that ambiguous grief that we encounter in dementia, that watching our person sort of die slowly, and how that affects us and the way we look at things? Will palliative help us with that?
Are you talking about, could you just clarify
that?
Yeah,
anticipatory grief.
Yes.
Where we're talking about an ambiguous loss, that where they're here but they're not here, and that sometimes is really, really difficult for the caregiver. And can palliative help us understand that grief that we're feeling.
Absolutely. Because really anybody who has been diagnosed with a serious, complex, chronic illness that we know will ultimately end up as the reason our loved one dies, we all have that anticipatory grief. And especially if you're watching somebody leave us a little bit at a time, you can no longer do this, they can no longer do that. It's beyond sad. And you experience a little bit of loss just about every day. And with that loss going on and still having to live your life as though this really isn't happening is just a horrible thing to have to go through. And the palliative care service with the chaplain and the social work can help address those things, help deal with that, and help understand not just how normal it is, but how you can cope with it, give you coping strategies for that. And then I think sometimes, even after the death of your loved one, some people feel relief and feel guilt for that. And that is something that is also normal. But you can feel bad for not just feeling sad, but feeling relief and having to deal with that. And that's something that is experienced by a lot of people and is completely normal, but you still have to deal with those feelings.
So, in other words, would you feel that becoming involved with a palliative team at diagnosis would basically help you in all aspects of the care so that you're more prepared and you have the resources you need to survive this? Because we know the statistics of caregivers of those with dementia are frightening. And palliative care can help alleviate some of that, couldn't it?
Absolutely. I think, support for the caregiver is just as important as care for the patient, and giving you the resources, checking on you, and helping to make sure that your needs are being met. Not just your social needs, but your physical needs. I mean, people who may experience depression or extra anxiety. Who's helping you with that? Who's navigating that for you or with you? I mean, palliative care takes this walk with you. It's not just you on your own. And so many people try to do it on their own or are looking for what they need and they can't find it. And the resources that palliative care has can help you navigate this journey, and the healthcare system, which in itself is so complex.
Rita, do you feel that something like that would be very beneficial for you as a working partner?
Yeah, I do. As I'm learning more about palliative, it's like, yeah, I will definitely be checking in to see who I can find that's halfway local, and whether they're in clinic or in home, or yes, I'm definitely going to be doing some research and pursuing that.
And do you feel, Rita, that in your position of having to work and having a husband at home with FTD, I'm sure that sometimes gives you a little pause now and then, is because we know they have good days and bad days, and would it help for you to have someone in the medical community say, Rita, it may be time for you to have some home health care? Would that be beneficial to help you make that decision?
Yes, because that's always one of my questions. When is it time for the next thing? And you're just making your best guess and doing what your gut's telling you, but you don't really know if you're exactly right or not. So yeah, having someone else either agree with you or explain maybe why you might not be thinking in the right direction would be very helpful.
Do you feel that, Dr. Kattine, that the palliative team addresses that?
Yes, absolutely. Absolutely. In rural areas, sometimes there are special setups with telemedicine or home physicians who do home visits, or even or advanced care practitioners who will do home visits. And that's something else that you might want to look into. And I know he might not be as open to having strangers in the home and having them come out, as you said, and having him get used to having people come out might be a good plan.
My next step was to hire a cleaning lady who actually does home health care. You know, there's agencies out there that will do both. So he thinks that they're going to come in and clean for me, but actually somebody's in there maybe once or twice a week, kind of just checking on him during the day, and he gets used to that in and out kind of thing. That's my plan for my next step.
That's brilliant.
We call them therapeutic fiblets.
Yes. I also have my pre-stops out every couple of weeks. So he's, you know, that was the first step of somebody in and out, somebody he was familiar with. So Father Jim comes in and checks in with him, you know, 15, 20 minutes every couple of weeks. So that was step number 1, to get him used to somebody coming in and out. And this is step number 2.
Janelle, let me ask you this. Do you feel that if you had a palliative team in place, it might have made a difference of when Keith went into memory care?
Oh, definitely. Definitely. You know, when you have somebody in their 50s, for one thing, the facilities are really not set up for someone in their 50s. And I called myself the bull in the china shop that was going to get what I needed sometimes. So yeah, it would have made a difference, but I don't know now. I think they have changed so much in the medical, and I'm not in a rural community. I'm in Bloomington Normal. I've got resources, and I've got, resources in Champaign, which is 50, 60 miles away. And it was actually the neurologist who helped me get the primary on board with, there's no turning back. It's just going to march on, and we have to, so it would have made a difference. And I guess I didn't explore it. I was working, when you're in your 50s, you can't just drop everything. So I really want to bring palliative to the forefront, because I know I'm in a support group now where when I was the 5th person to join it, and I am the coordinator, and I now send out emails to 26 people monthly. So I think at the time there wasn't, back in 2009, there wasn't a whole lot of, I hadn't heard of FTD, and so many haven't heard of FTD. But I think now it's not being so misdiagnosed. That's how our support group feels, is that we feel like, well, some of those people were like Rita's, where it took, years to be diagnosed, but more of them are being diagnosed sooner. And I think if they're getting that part of it right, then we need to get I call it the missing link, put together too.
Dr. Kattine, could you just address some of the most important things that you think are necessary for someone getting a dementia diagnosis that palliative care can assist in? What are the most important things that palliative brings to the dementia diagnosis?
Gosh, when I think about somebody getting a dementia diagnosis, the first thing that they're going to need is a lot of social support. And they're also going to need to have someone talk about what this means for them and for their family, which I know is going to be emotionally difficult, but it's something that needs to be done. And talk about the natural course of what happens. And then knowing those things, I think you need to find out what's important to the patient before, while they're still early on in the illness, and they can communicate what's important to them, how they want to live their lives. What can we do to make sure that he gets to live or she gets to live the life that they want to have as well as they can, given the reality of their situation. And of course, involve the family in these discussions too, because it's important to the family to know what's important to the patient and get the advanced directives taken care of. What do you want to make sure you get or don't get? Advanced directives can address a variety of things, like not just code status, meaning do you want CPR when your heart and breathing stop, but would you want feeding tubes? Let me tell you, feeding tubes aren't going to help you if you get to the point where you are unable to swallow. Feeding tubes aren't really going to help you live longer or better in dementia situations. In others, they've got their own place. But also in the advanced directive, you can talk about withdrawing or withholding treatment. And when people say that there's nothing that they can do, what are they talking about? Say, well, there's always something you can do. It might just not be something to help you live longer, but there's always something that can help you live better. And so having these kinds of conversations, also getting the the financial power of attorney in place so that you've got somebody who can help manage your finances, write the checks, make sure your bank accounts and your safe deposit boxes all can be accessed by somebody that you designate. You need to have all these things in place early on so that when the dementia progresses, that you're not in a bind figuring out how to manage these things. Help you navigate which hospitals or no hospitals, which home services or no home services, and bringing other people in, like the cleaning lady, to help you do these things so that you're prepared for what's coming down the road. If you know it at the beginning, it makes it easier when it's time and you're not having these conversations in a crisis. You have it prepared.
Go ahead. One thing that happens in our world a lot is because people know of hospice and they're asking for a hospice referral, and hospice says, well, no, they're still walking around, they're still talking, they're nowhere near hospice. And 2 weeks later, all of a sudden, they're not eating, they're losing weight, and they're in hospice, and they're only there for a week. Will palliative help that transition to get hospice sooner, even though those guidelines for dementia and hospice are geared towards an older population who are not walking and talking at that time? Will palliative help us with that?
I sure hope so. Nothing's perfect, but I would sure hope so. And those Medicare guidelines for hospice, for different diagnoses have not been validated by any science. That was created decades ago, and they've not been refurbished. They need to be. And so often the people who are doing the admissions for hospice don't really understand the different kinds of dementia, and that's something that they could benefit from. If you've got a palliative care service that is familiar with it, even if you've had to educate them on what it is, that they can document to make the hospice referral appropriate.
Because if they're involved from diagnosis, they are very clear on when things are diminishing. So they can clearly see that this person is not who they were the day they came in for that initial palliative conference. It becomes very clear that, well, they may still be walking and talking, but this is not the person that I initially saw. And will that help sort of promote hospice?
Yes, absolutely. When you've got a provider who has witnessed the decline, can document the changes, and gives his or her opinion about the life expectancy, that goes a long way. It takes two providers, 2 physicians to say somebody has a terminal illness or a life expectancy of 6 months or less. One is the referring or primary physician, and the other is the hospice medical director.
But if that palliative team is involved and has been working with that primary physician, that would be very beneficial for if the primary physician, it seems to me, would be the primary person that would say, yes, this person is qualified for hospice, even if that hospice physician is not as familiar with a younger onset dementia, that could help, correct?
Absolutely, absolutely. And that referring, the palliative service can give the medical information if the hospice medical director is less familiar, and provide the references and the information about their particular illness, in this case, FTD, to help the medical director understand what's coming down the pike and why this referral was made.
That's very important, because we have many people that are in and out and in and out and in and out of hospice. And yet they're declining, and their caregiver is in the same position they were before hospice came in the first time. They're left with that total care again that they needed, and have to fight to get it back. So I think that's probably another very good reason to get palliative care involved very, very early. We're coming up on almost an hour here, and we don't want people to have to listen all day. We could talk all day, but Rita and Janelle, I'm going to ask both of you, what do you feel out of this conversation was one of the most important things to have people that are diagnosed with dementia know about? Rita, go ahead.
To me, one of the kind of the aha moment for me was this should start day one from diagnosis. And I honestly, up until a few months ago, was not really familiar with it whatsoever. So that was kind of my aha thing. It's like, yeah, everybody should get going on this right away and see how it benefits you, see what you can get from it.
And Janelle, what did you take away from today?
My aha moment, which I didn't even put together until just right now, we changed our hospital providers we changed them in the beginning of 2009, and he was diagnosed in November of 2009. So I'm thinking the reason my doctor was so hesitant is he didn't see him before FTD. So that probably played a lot more into it than what I had just even thought about until now. So, if you have a primary that has seen them, I think they would probably more than likely, would see what we had seen, and maybe even see more than we had seen, because every day you just get used to, okay, today is today. This is where we are. And so because even with family, when they didn't see him as often, they could see the declines that I just rolled with. So.
And Dr. Kattine, what would you like to tell us is very important as a caregiver of someone with dementia? What do you feel are the most important steps for us to know?
That you need to advocate from day one. And as hard as it's going to be, before things get worse, to make sure that you've got somebody to help you with your resources, and to ask for palliative care at the time of diagnosis. And when the doctor tells you, oh no, it's too early, say, I'm not talking hospice, I'm talking palliative care. Please refer us as soon as possible, and we'll still come to you, but we need palliative care too. And that's what I would ask for day one.
I really appreciate you joining us, Dr. Kattine. I think you've opened all of our eyes to some of the things that we need to know in advocating for the people that we have that have been diagnosed with dementia, and make their life better. And I think that's all of our goal, is to make their life better and to reduce our stress in the journey. And I think that you've brought to light that that's what palliative can do for us. And we need to be very aware of the fact that it's there and available for us. So, Dr. Kattine, I appreciate you spending this time with us and explaining palliative care. And Rita and Janelle, thank you so much for putting your input in as to how your situations may have changed or can be changed by instituting palliative care. So thank you all for being here, and thank you for doing this. And we're going to spread this far and wide so everyone with dementia can have what they need. And thank you again, everyone, and have a wonderful day.
Thank you.
Thank you.
Have a wonderful day too.